We all know that stents these days are excellent in terms of the durability and the low clinical events. But ultimately, you're leaving something behind, and there's something called an attrition rate with stents, around 2 to 3% per year. And this risk is augmented in certain lesion and patient subsets. For example, if you're a diabetic, if you've got kidney failure, if you have a calcification in your coronary arteries, and if you're placing stents in the small vessels, these lesion and patient subset have a higher risk of stent failure. So in these patients, I think we should be focusing on leaving nothing behind by using drug-coated balloon. Now, drug-coated balloons were invented initially to address in-stent restenosis in those patients who have had a stent failure and you did not want to place another layer of metal, but instead use a drug-coated balloon. But now we think that drug-coated balloon probably is an alternative to stents in certain patient lesion subsets. Now, of course, we need evidence, and it is growing. As of now, the evidence lies in small vessels, long lesions, bifurcations, and patients who can't take dual antiplatelet therapy beyond a month. So, patients with bleeding risk or active bleeding or waiting for an urgent cancer surgery. So, in my practice, I tend to use DCB as a blended therapy, which means in combination with stents, or as a solo therapy in approximately 50% of my cases. And as I said, drug-coated balloon angioplasty has a longer learning curve. So as you embark more and more complex lesions, you'll get more and more comfortable. But the most important aspect of any drug-coated balloon angioplasty is the lesion preparation. One, of course, lesion selection is important because you don't want to embark two complex cases very early on. But equally, you don't want to, put stents in small arteries, especially what we call a full metal jacket, putting long layers of stent. We don't think that's the right thing to do, especially in the current phase of interventional practice. So there is a place for DCB, but evidence is lacking in certain large vessels. So that's coming over time. But if you ask me for long lesions, small vessels, DCB is excellent. For bifurcation, it's great because it simplifies your angioplasty, especially when you have complex two stent strategy, which can be time consuming, can have failure, whereas DCB helps you simplifying. So you can treat the side branch with DCB and stent the main branch. In some bifurcation, if it's small vessels, you could use DCB in both branches. So for me, yes, DCB is a growing field, a growing interest. But again, equally, we have to be cautious in the sense we shouldn't use DCB in all cases, and we need to, focus on lesion preparation. We have to proctor operators who want to use DCBs. So yeah, I think it's a great technology, and I personally feel this is going to grow, and there'll be more and more DCBs used over time across the globe.